Thank you for listening to this presentation about Torbay Hip Score project. My name is Rangaraju Ramesh. I'm an orthopedic consultant working in Torbay Hospital in Devon. Anesthetic team use ASA grading to class anesthetic complexity, but surgeons do not have a system to grade surgical complexity while performing a hip replacement. We are very pleased to present our work on a pilot study aimed to try and understand how we could objectively grade surgical complexity of hip replacement as complex primary hips. We also present the importance of having such a system and how this could potentially benefit list planning, documenting progress of training, and validation of outliers in NJR data. We did this essentially by looking at the records of patients who were already on the waiting list for surgery, and none of the decision making was changed or influenced as a result of this pilot project. Our findings were presented as a poster in BHS, EHS, and EFORT meetings this year. The surgical aim of hip replacement is to place the chosen implant in the most optimal position to recreate the anatomy and thus to increase the longevity of the implant. However, getting this right every time is not easy, as not all hip replacements are equal or same. Many factors influence the final outcome. Patient factors, surgeon's expertise, the role of the surgical team, implant design and its track record, and the perioperative processes, to name a few. Despite all of these, the success or failure of the surgery is almost always ascribed to the named surgeon. One area where the surgeon should have a total influence is determination of the surgical complexity and choosing the most appropriate implant. Whereas there are a lot of information about choice of the implant, very little has been published to present a universally applicable grading system to classify surgical difficulty. So, what is a complex primary hip? This is a phrase used when some form of technical challenge may be encountered while performing the hip replacement surgery. More often than not, it appears to be a gut feeling that is expressed by a surgeon, tempered by his or her experience. Trainees often get amazed when their boss looks at the X-ray for a few seconds and tells them that it is a difficult hip replacement. They also notice that what is a complex hip replacement for one turns out to be an easy operation for another surgeon, and vice versa. So how do we translate this gut feeling reading into a tangible, objective grading process? The objective of our QI project was to find out how surgeons come to the conclusion why a particular replacement is deemed to be difficult surgical procedure. It is clear that they make a subconscious decision, but we wanted to find out if there was a way to tease this decision-making process into an objective, reproducible system. We started off with literature search, which spanned over many years. After a slow start, we got some time during COVID pandemic, and we were able to devote more time to this project. Multiple rounds of literature searches were conducted with the keywords as shown, and we got over 900 hits, and using various tools, in the particular using Ryan QCRI, we were able to swiftly trawl through all the abstracts to make sure that we were not missing anything. After the extensive literature search, it was indeed a bit surprising to note that there was no universally acceptable grading system to define the surgical complexity of a hip replacement. This may be because there are many factors that seem to influence and determine the complexity. Moreover, the literature is heavily slanted towards a diagnosis-driven complexity determination, wherein subtle reasons why a particular diagnosis makes the operation more difficult were discussed in great detail, but there appeared to be no attempt to link all of the variables together into one system. In fact, this was the reason why NJR minimum data set forms, which at one stage collected if a hip replacement was complex or not, was subsequently rescinded, mostly because most surgeons selected every replacement they do as complex. So we attempted to break down each of the components that creates the problem at anatomical level. it became apparent that the complexity was determined by multiple factors and the levels of changes in the anatomy, either alone or in combination, ability to perform the operation safely, and how a post-operative rehabilitation would be influenced were all seemed to play a significant role. We consolidated various components into sensible groups. Simultaneously, we decided to try and match this to one's instinctive gut feeling as well. For determining the gut feeling classification, we identified a random selection of patients who were already on the waiting list, where the listing surgeon had marked the operation to be complex primary replacement. 12 surgeons of varying grades in the department were sent a request to review the x-rays and to state if they would consider this to be complex or not, and the reason for the same. The response allowed us to fine-tune the evolving objective grading system. Subsequently, all authors reviewed the components that made up the scoring system before trialing it. There are 5 components in the main scoring system. This can be determined with the standard AP and lateral radiographs, which are routinely taken for planning total hip replacement, and further information as needed is gathered from the case notes. For example, BMI, spinopelvic asymmetry, neurological status, etc. We also realized that the difficulty of the operations could be determined by combination of multiple components, or sometimes a single component on its own could make the operation challenging. Some components were mutually exclusive. For example, if you have a valgus neck, you cannot also have a varus neck. The 5 components are related to the anatomical factors in acetabulum or femoral neck or femoral shaft. Local factors and general factors were the other 2 components. Depending upon how severe each variables were within these components, a particular score was given. So, what are the factors in the acetabulum? The acetabulum could be medialized, for example as in protrusio, or lateralized, for example in conditions with shallow sockets. There can be multiple cysts which will influence the safe placement of the implant. Roof erosions at the superior lateral corner can also be affecting the secure placement of the acetabular implant. If there are any wall defects, or if there are any pre-existing implants, depending upon the need and the difficulty of removal, will all form a part of the scoring matrix. The femoral neck components were made of hip length difference, if the neck was too valgus or varus, and the level of the offset. Medullary canal shape, bone defects, deformity due to metabolic diseases like Paget's or secondary to fracture, or osteotomy and presence of implant, and the types made up the femoral scoring matrix. The local factors included arthrodesis, local cancer, usually secondaries, their location and the extent, fixed flexion deformity level reflecting spinopelvic axis relation, and the presence of any amputation in the limb in question. General factors that seem to affect either safe performance of the operation or rehabilitation included BMI, or if the person had a flaccid or a spastic paralysis. Thus, there were overall 20 components that made up the scoring matrix. In each component, the score was based on the severity of the derangement of the anatomy. Most of the scores ranged from 0 to 3, but for some it was 0 to 2. A traffic light system to grade the surgical complexity was agreed, and the hip replacements were separated into simple or green hips, hips of intermediary complexity or amber hips, and complex primary hips or red hips. We also recognized that sometimes each of the score values were additive, and sometimes just one single component could make the operation complex. Here are some examples of different hips. This is a green hip, this is an amber hip, and this one is a complex primary red hip. The first round was done without collaboration regarding how one would apply the scoring system. At the end, all the 6 observers agreed correctly on which hips were deemed to be surgically difficult. That is, 100% agreement on red hips. In over 60% of cases, at least 5 observers agreed on green or amber hips. Where there was a disagreement of more than 2 observers, we analyzed this further and a second round of scoring was done. Subsequent to this, the correlation significantly improved, whereas 100% agreed regarding red hips, more than 80% agreed regarding green hips. There was still some disagreement seen for amber hips, and this was inversely correlated to the experience of the surgeon. What are the uses of the scoring system? We wanted to highlight the advantages of having an objective grading system for determining the complexity of hip replacement. This will be useful for accurate list planning by placing correct combination of complex and simple hips. It will allow appropriate use of resources, team mix, and seek appropriate help from senior surgical member. It will allow to plan the list timing, planning day case hip replacements appropriately, and to have the right surgical kit available. It is also likely to map the progress of the surgical capability of a trainee, and they can demonstrate that they are progressing sequentially by performing more and more complex hip replacement as their training year progresses. In conjunction with patient decision aids like Torbay charts, it will also help in shared decision-making discussion with the patients and obtain appropriate consent by objectively explaining the complexity of the operation. By mapping the outcome and correlating this with the NJR outcome funnel plot, it can potentially support an outlier who's taking on difficult operations. And for the trust finance department, it allows the possibility of requesting a higher tariff for performing red hips, as inevitably it is likely that more expensive equipment or additional theatre times will be needed to safely and effectively perform complex hip replacement surgery. What is the future of this scoring system? This is a very small scale pilot, and it has demonstrated that this concept is eminently reproducible. However, a much larger scale pilot is needed to see if this can be applied universally, perhaps with the help of an easy to use phone app. In an ideal world, we should map the outcome of hip replacements and correlate any complications to the surgeon's grade. This is best done prospectively. In an ideal world, it should be a multi-centered trial. Unpicking which component is important and where to set the grade boundaries can only be done with a multivariate analysis. I thank all the 12 contributors who helped in the initial pilot. With BOA and NJR support, we can develop a similar scoring system for other major joint replacements like Torbay knee score and Torbay shoulder score.